Referral, Moi Teaching and Referral Hospital. I want us now to have a discussion here in studio. Joining me is Dr. Alan Chengji. He's the Vice Chair of KMPDU. He's also a dental and oral implant surgeon. Thank you for your time here on the show.
Thank you, Betty.
All right, so we wanted to hear from your perspective. We've had the Kenyans who've just highlighted the experience they've had, but how serious is the situation at both KNH and Moi Teaching Referral Hospital as we speak?
Thank you for having me. We find ourselves once more in a tricky situation, unfortunate one for that matter. That started with an error where a patient had a wrong procedure performed on him. And then with that came the boycott of duties by the doctors in training, otherwise known as the registrars. The situation is not good. When doctors withdraw services, it's never a laughing matter.
Right.
So someone's life is usually at stake. But the background of this is that we have registrars who are working in Kenyatta, and there's an MOU between University of Nairobi and the Kenyatta National Hospital, which we are not aware of. We would want a review of that, because that results into Kenyatta being a referral, depending entirely on University of Nairobi students to perform the duties. We'd want a review of that MOU so that Kenyatta National Hospital concentrates on referral duties, and then University of Nairobi concentrates on primary role, which is teaching the student, so that we don't have a mix-up. And then this is tied to the unfortunate event that happened at the Kenyatta National Hospital. And let me put it this way, that the reaction we are getting is, in our view, more of a knee-jerk reaction. We have underlying issues and systemic problems that would result into this. Unfortunate as it is, let us use it to interrogate the gaps that will lead to this.
That have been there. And we'll get to that shortly, also speaking about the suspension of Lily Koros, really, if that is the silver bullet. But before we get to that, you've correctly described the situation, as we've heard for the last couple of days, that indeed the registrars take up a larger chunk of the work at KNH. Actually, I was reading somewhere it could be about 85% of the work. I'm not sure if that number is correct, but a larger chunk of the work. But maybe you could just describe to Kenyans, what exactly, is the difference between the registrars, the consultant doctors, and, just why we are having, all these registrars, going up in arms against what happened?
No, for the sake of the public, a registrar is not someone it's a qualified doctor. He has done training. He has gone and worked for a number of years. He has come back to enhance his skills in a given field. So he's neurosurgery, general surgery, maxillofacial surgery. He wants to be super in his area of specialization. Now, when they come back to the university, there's an MOU which I've already highlighted between UON and Kenyatta National Hospital. So they find themselves working entirely for Kenyatta National Hospital, which account for maybe up to 90% of the work they do. Now, that's a registrar. Below the registrar, there's what you call a medical officer. In terms of hierarchy, we'll talk of a medical officer first, then you go to a registrar, then at the apex, you have a consultant. So when any procedure is done, in terms of referral pathway, you start with the medical officer. Whatever they can't handle, they are assisted by the registrars. And then whatever the registrar cannot handle, they go to the apex with the senior consultant. Yeah. Now, in any setup, even whatever happening in Kenyatta National Hospital, as you're aware currently, our professors and the lecturers, they are on strike. So the registrars cannot work alone because they don't operate in a vacuum. They work under the instructions of the senior lecturers and the consultants who are in Kenyatta National Hospital. Most of the lecturers and the consultants, again, at Kenyatta National Hospital, they operate from the university. So if you have a strike at the university, it goes to the apex of affecting whatever is happening at the Kenyatta National Hospital. That's why we're saying we need a separation, so that whatever happens at the university does not affect operation at the hospital. But
let's also talk about that surgery mix-up last week. So can you say really that it was, a medical mistake, or was it occasioned by the fact that the lecturers are on strike and there was nobody really to supervise the registrar who was at hand?
The incident was unfortunate, but then it does not amount to medical negligence or incompetence in the part of the person who was performing the surgery. Because look, the person went, he had the competence, he knew what to do, he went in and opened the skull, and then took a moment and said, hey, whatever I'm looking for is not in this patient. And he didn't hide it. He took a back seat and then informed the senior that, look, this is what I'm expecting, but this is not what I found. So what do we do? Now, what's happening here is there are systemic problems that would have accounted as to why there was a mishap in terms of the filing and the documentation. We have a lot of things that the public should know happening in Kenyatta. Kenyatta is overstretched. With that comes poor record keeping. Nowadays, we have barcoding, we have things to do with biometric identification, which are lacking. And with that also comes with inadequate and skewed human resource allocation. We don't have enough staff. You have a case where one nurse is manning a ward of over 70 patients. Some are sleeping on the floor. With that, again, the theater space is small. The ICU beds are squeezed. So in all that system, there could be a mix-up. So an error occurred. But let's use that unfortunate event to interrogate deep-seated issues that will result into avoidance of such an occurrence.
Right. And it's interesting that you say that, because even yesterday, just listening to the consultants, they had quite a number of issues, including the fact that, you know, even the equipment used at the hospital date up to 1982. As a doctor, what can you highlight as some of the biggest challenges right now facing KNH?
KNH is, as I've said, is overstretched completely. We have patients sleeping on the floor. Some of them, the way they're admitted, usually we give them names. Someone comes unconscious, cannot talk, they don't have relatives. So you give them a known African male. In one ward, you have 2 unknown African males. They can't talk. They all need to go to the theater. That will lead to the mix-up. Kenyatta is overstretched in the sense that the theater space, the one that was operating in the 19th, wherever, it's still the one that's there today. The ICU bed, we had an unfortunate event where someone died in an ambulance simply because we could not get a space to accommodate them. The number of ICU beds are still minimal. The number of doctors and nurses working there. And for your information, myself and 6 of my colleagues, we went to jail talking about this thing. So we never want to sensationalize something, but we've been at the forefront of talking about these things day in, day out. And then all of these things are capped up by skewed resource allocation, bad governance, and interference from the political class, where we don't have the opportunity to perform the things that we need to do in an environment that is enabling. The equipment are missing, the number of personnel is skewed, and everything is just chaotic.
But this narrative, I mean, we've had it before. Even as media, we've gone to the wards, we've seen people, you know, sleeping on the floor, the unfortunate, you know, environment that the patients, you know, have to undergo when they're getting treatment. But why is it that there's really nothing being done? What is that thing that is stopping all this change? Is it a financial issue? Is it human resource? Is it that we don't have the right people who are leading this institution?
Maybe our priorities are twisted, because one, we have minimal resource allocation in terms of cash. Now that interferes with everything, because for you to have the right HR, you need to hire. For you to have good equipment, you need to spend money. For you to have good record keeping, you need to spend. Now, if you're given minimal budgetary allocation, you're not able to do that. And the second thing is we have sort of some political interference where the Kenyatta as a parastatal and as hospital is not allowed to function properly. Suspending Lily Koros as we speak.
What does that mean, this political interference? Who's interfering with this? Is it people from government? Who is this person? Because we always talk about political interference in many instances.
Well, there are high-handedness where someone is not allowed to perform his or her duty fully. Like right now, suspending the CEO. Without it, in our view, it's more of a knee-jerk reaction because there are deep-seated issues. Even if you suspend the CEO today, suspend the next one, suspend the one that will be coming after. You are not addressing the bed space. You are not giving more resource allocation. So we should direct our attention towards more of policy, which happens at the political class level, than focusing on the individual who is supposed to be performing his or her duties based on the policies driven at the top.
Right.
That's where we get it wrong.
All right. Also, the KNH is is a referral hospital, and one of the issues that the consultants yesterday were raising is that everybody goes there. You have somebody coming from, say, Kitui or Mombasa. They pass so many hospitals coming to the same place. So who should be responsible for, to make sure that, there's no overstretching of resources also on KNH, even as Kenyans try to seek these services?
Exactly. Like in Kenyatta, we proposed a very good model where you need to expand the periphery hospitals. Mbagathi Hospital, for example, you need to elevate it, give it room to perform more procedures. Go to Mamaluzi Hospitals, also upgrade it, allow it to perform its duties. Then you go to somewhere like Kiambu, Machakos, and the surrounding hospitals. If you do that adequately, it will lower the numbers. The problem in Kenyatta is that everyone wants to come there, and you can't blame them because that is the only place they can go to. As we're talking to you today, there are a number who are lining to get admission there because in their mind, the only place of health they can go to is Kenyatta National Hospital. So we need to work on the peripheral hospitals to help decongest KNH and also to allow it to perform its referral activities.
Right.
We should only have super speciality being performed at KNH, and then the simple procedures can be performed at the periphery.
All right. Last year, of course, we had that 100-day strike, by doctors, and you mentioned correctly that some of these things are what you were agitating for. Sure. What can you say has changed since that strike?
Well, every day is a learning lesson, and we get to improve day by day. But the space is what is alarming. So that even if you made improvement today, it will be so minimal compared to the occurrences that are happening. In as much as we were agitating for some things, we didn't achieve all of them. We got one or two things. We got, it's called the collective bargaining agreement.
Yeah.
But now the implementation of it, it's another thing. Because with that document comes budgetary factors I was talking about. It talks about how disciplinary action should be done. It's not a knee-jerk reaction where we are seeing happening in KNH. We have competent bodies. We have the Kenya Medical Board. We have the Nursing Council of Kenya. Have they been given duty to interrogate the situation and come up with an audit and then point out, say, this is what went wrong. This is how we can do it to avoid these things. So in as much as we got that document, implementation is still dragging, and we have not reached the point at which we should be as a country.
All right. Moving forward, one of the biggest agendas of the government, as they promised for the next 5 years that they will achieve in the 5 years, is of course one of it really was to improve healthcare for the Kenyan. What do you think are the things that need to be done? And do you think there's political will really, or is it just talk? But is there really political will on the ground to ensure that if KNH is facing budgetary issues, then we allocate more money, into changing how things run there?
We've seen none other than the head of state coming out to commit in his Big Four agenda, health being one of them. And to that extent, the intention is commendable in terms of talking about the universal health coverage. But usually the devil is in the details and how this thing is going to be implemented. Right. We want to be in the forefront of giving expertise advice and chipping in where necessary to make sure that this thing works. Because if it at all takes off, it will take a huge burden of financial payment in terms of health to those who cannot afford. And then we not have these scenarios where everyone wants to go to Kenyatta National Hospital simply because that's where they can afford and that's where they can get the expertise that they need.
All right.
It's a commendable effort to have that.
Right. So I want us also to just talk about the Moi teaching referral. But before that, of course, KNH has been dogged with quite a number of scandals or things or mistakes that Kenyans have come out really to complain about, really. Of course, you'll remember the child theft, you remember the rape allegations. These things from a layman's perspective seem like they're so obvious that, when a mother is in hospital, they're supposed to be secured. Not even a mother, anybody, any patient who's in hospital needs to be secured. That when a baby is born, there needs to be, processes that ensure that this baby goes with the right, parent home. How come that these seemingly obvious things are not so obvious to, to a hospital like KNH? Does it go back to the resource issue you're talking about?
Maybe some things are, much as they are obvious, maybe they may not be so obvious. In the sense that KNH as a hospital is, let me say, a society on its own. So there are things that happen in KNH that are related to security matters.
Yes.
There are things that are non-medical. You have laundry services. You have mortuary services. And sometimes the occurrences are unfortunate. And to that extent, whoever is found culpable should be held liable. But let me say that some things touch on the core mandate of the respective areas I've talked about. If it's security issues, it cuts across. There's head of security in Kenyatta. It has nothing to do with the person who is providing the service. When a patient has been done for a procedure, they go back to the ward. They need to be taken care of in terms of security like any other Kenyan, so that if anything happens, the person who has committed such offense is held purely responsible. As I've said, whatever is happening in KNH is a society on its own. So it needs support system. It needs security, laundry services, a motor vehicle, you have drivers, you have watchmen, all these people interact in a given society. So whatever would happen outside will still happen there. That's why we need strict supervision and a strong support system, and we cannot delink it. It boils down to resource allocation.
All right.
Because to perform all these things, you need money.
Can you say the same situation affecting KNH is the same one that is affecting the Moi Teaching Referral Hospital?
Maybe not, maybe the same, because even MTRH has challenges, but probably they don't come back to the media houses as much. Whatever is happening in KNH would be the same thing happening in Mwingi or in Migori, for example. It's just that they don't come to the media. Because of the skewed resource allocation and maybe inadequate HR issues, you will still have cases of exchanging of drugs where patient A is supposed to receive drug B and they swap it. Maybe radiation in terms of X-rays, you get patient A getting the X-ray for the patient B. These things still occur, but not to the magnitude. Maybe because the referral facility is in the heart of the capital, so the attention and everything comes to the fore. But all these things cut across. If you go to Malindi, they still have their challenges.
All right. Let's go also to the counties finally as we finish. Do you think that if health was 100% completely devolved function, it would be better for the Kenyan?
Devolution 100%. Is a good thing. There are aspects of it that have worked. There are model counties like Turkana, which have done very well. But the same capacity in which we are talking about Turkana, there are counties who have done very poor. The spirit of devolution was to take services close to the people. Unfortunately, it was hurriedly done, and the human resource aspect of it was completely ignored. So when people talk about devolution, they think about building dispensaries, putting some equipment there, and then calling it a hospital. Hospital is nothing without those people who work there. Even the medical equipment scheme that was spearheaded by the head of state, we've had it stalled in some areas simply because you don't have people to run behind it. Now, what was done wrong is the sense that it's the human resource aspect is because things to do with continuous training is not taken care of. Things to do with fair remuneration is not adjusted. Promotion, there are those who stagnate for more than 5 years. They are not motivated. Things to do with that transfer. If you want to get from maybe Machakos to Kitui, it's hell on earth. These are the simple things that keep people motivated. Money enough is never motivation. You need something, an enabling environment for this person to work. Now, looking at the infrastructure without putting to it the accompanying human resource, that's what has made the devolution of health a whole challenge. And the governors and even the concerned people, they've never gotten it right. Because they think, as Doctors Union, we are fighting devolution. Contrary to that, we're not. We just want it to be addressed in a sober, a correct way, where we don't have interruption. No one is interested in strike every now. Life is at stake.
And the thing is, so which one would you as doctors and especially the union prefer? Who would you prefer handle this money? Was it wholly taking it to the counties or just leaving it to the national government too? Because it seems like there's nowhere where things are being done the correct way.
Any day, any night, our preference is Health Service Commission. Where all these things are managed at a central point. So that someone, because right now, if you're working in Machakos, for example, you will never go and give your services somewhere in Mandera, for example. If you have a central body, they'll be stuck with the mandate of ensuring adequate distribution of doctors, that training is guaranteed, their payment is done correctly, they are promoted, and all these other things. But you see, right now, the way the counties are done, sometimes, unfortunate as it is, your name has to come into play for you to get some of these things. So if it's done centrally, then it will be very much easier. And it has nothing to do with taking resources back to the county or the national government. We just want a body to manage all these resources together.
All right. Thank you very much, Dr. Alan Chengji, talking to us really about the health crisis here in the country, the situation in a number of hospitals, including KNH and the Moi Teaching and Referral Hospital. Thank you for your time. Let's hope that things,
yeah, we hope
get better. Let's hope that this time around with the uproar, we will have something
let me hope when I come back, we'll be discussing the improvements.
The improvements of it. Yeah. All right. So Dr. Alan Chengji is the vice chair for KMPDU. All right. So we have some devastating news, and we understand that renowned scholar and former University of Nairobi Chiromo campus principal, Professor Oweri Tumbo, is dead. Professor Tumbo, who was a regular panelist here on KTN News, died this morning from what is suspected to be heart attack. Some unfortunate news there. I'll repeat that again. Renowned scholar and former University of Nairobi Chiromo campus principal, Professor Oweri Tumbo, is dead. Professor Tumbo, who was a regular panelist here on KTN News, died this morning from what is suspected to be a heart attack. Such sad news coming here, especially for the KTN News fraternity. And he used to be a regular panelist, like I mentioned, here on KTN News. So it's really a sad loss and a devastating one. May his soul rest in peace, and condolences to his family and friends. All right, so we'll take a short commercial break. We're coming back to continue with our coverage. Don't go away.